Hello, I'm Dr. Scott Carroll. I'm a board-certified child and adolescent psychiatrist and the founder of the INE Neuroscience Institute in Albuquerque, New Mexico. I'm also a former associate professor of child and adolescent psychiatry at the University of New Mexico School of Medicine. Today I'm going to be talking about autism spectrum disorder in order to give people a basic concept or understanding of the diagnosis and treatment of this challenging condition. This lecture is appropriate for both lay people and mental health professionals. Though obviously if you are a psychologist who extensively works with autistic spectrum disorder, you'll probably find this a little simplistic for your purposes unless you're just interested in the medication aspects of treatment. So let's begin with what is autistic spectrum disorder. So that's a great question. Perhaps the best way to think about it is as a complex neurodevelopmental disorder characterized by difficulties in social interaction, verbal and nonverbal communication difficulties, obsessive interest, sensory sensitivity, also known as tactile defensiveness or sensory defensiveness, rigid and repetitive behaviors, and severe and prolonged tantrums, especially in children. So autistic spectrum disorder was actually developed from four previous disorders that were found in the DSM-4 and previous versions of the DSM. Autistic spectrum disorder is new with the DSM-5, and the purpose of this new disorder was to better describe clinically what was seen. So the four previous disorders were autism disorder, which we now sometimes refer to as low-functioning autistic spectrum disorder, Asperger's disorder, which is sometimes called high-functioning autistic spectrum disorder, pervasive developmental disorder, NOS or not otherwise specified, and of course childhood disintegrative disorder, which is extremely rare and most people are not familiar with nor have heard of. Of course, the reason for this change wasn't just to better describe the spectrum of symptoms seen clinically, but it was also made to address the issues with services and treatment that many individuals had, particularly those who had a blend of autistic and Asperger's symptoms and thus didn't neatly fit into either category, often ended up being denied services and treatment previously. This issue has been resolved with autistic spectrum disorder, though many researchers still use the previous criteria because of their narrow definitions, which are useful for research purposes. So the history of autism is quite lengthy. In fact, there are reports from the 1700s about feral children that closely resemble autistic spectrum disorder. Now, obviously, we can't go back and test them, some of these feral children, of course, were raised in normal homes, so it can't be said that they were literally raised by wolves. Though the term autism originated with Eugene Bleuler in 1910 as one of the features of schizophrenia and not as a separate disorder. Then, of course, Hans Asperger of Asperger's fame used the term to first describe individuals in 1938, which he called autistic psychopaths. It was later Leo Kanner, who was a professor at Johns Hopkins University, associated autism with young children in the term early infantile autism, which came out in 1943. However, it was not till the 1960s that autism and infantile schizophrenia, as it was sometimes known as, were firmly separated in the late 1960s. And this separation was further finalized with the DSM-III in 1980 as clearly defining the criteria for both disorders to be distinct and separate and to not overlap. Unfortunately, however, both conditions, both autism and schizophrenia, were falsely attributed to the, quote, refrigerator mother. We now know that that distinction is absolutely not true. And in fact, actually, part of the mother's behavior that made such mothers appear to be cold and distant were actually driven by the child who was unable to tolerate close social interaction and eye contact. Now let's switch gears and talk a little bit about the high-functioning end of autistic spectrum disorder, which was previously known as Asperger's. Of course, Asperger's was named for Hans Asperger, and it was formalized as a diagnosis with the DSM-IV in 1994 and in the ICD-9 in 1992. However, while the condition is named for Dr. Asperger, he did not originate it. We now know that a Russian psychiatrist named Grunya Sukhareva also described it in 1925, and her work was actually translated into German in 1926. So it is possible that Dr. Asperger's was familiar with her work and borrowed extensively from her. Interestingly, though, Dr. Asperger, the condition he described, more readily resembled the full spectrum of autistic spectrum disorder and not the more narrow disorder described in DSM-IV. Interestingly enough, Dr. Asperger was also a strong advocate for inclusion of such individuals in society because he felt they had numerous contributions to make. And even though they may have deficits in certain areas, he felt that their strengths could be used to great benefit. He often called them his, quote, little professors and described them as somewhat clumsy idiosavants. Many famous people have been diagnosed with Asperger's over the year, or what now we would call high-functioning autism, perhaps the most famous of which is Bill Gates, the founder of Microsoft. But two comedians, Jerry Seinfeld and Dan Aykroyd, have publicly admitted that they were diagnosed with Asperger's. And there's strong evidence that Albert Einstein likely had autistic spectrum disorder as well, given that he showed many autistic features and didn't speak till he was approximately 5 years of age. So let's talk for a moment about how classic autism or low-functioning autism and high-functioning autism or Asperger's are actually similar. They both have difficulties with transitioning or switching from one activity to another, and often this is a major trigger for outbursts, has to do around this type of transitioning. Both show strong tactile defensiveness and sensory sensitivities, including intolerance of temperature differences such as being hot or cold, pain, or even hunger. And the result of oftentimes this type of intolerable sensation is a severe outburst and prolonged tantrum. Both have rigid adherence to systems, patterns, and routines, violation of which often leads to the previously described outbursts. This is basically due to both types of autistic spectrum being unable to adapt to the environment and requiring the environment adapt to them. As I previously stated, both forms have explosive aggression and prolonged tantrums when they're triggered, whether it's due to sensory issues, transitioning, or violation of routines or patterns. These type of explosive aggression and prolonged tantrums are striking in that they can be extremely violent with self-injurious behavior, and they can last literally for hours, with no webbing, with no waxing or waning in the course. Both types of autism engage in various repetitive behaviors, from rocking and headbanging to hand flapping, which is pathognomonic for autism. Also, treatment is very similar, especially when it comes to psychiatric medications. Now let's take a moment and talk about how autism and Asperger's are different. A good way to think about it as left and right hands. While they both have fingers and thumbs and look very similar, they're actually mirror images of each other in certain ways. So in the case of autism, when it comes to social interaction, people with classic autism or low-functioning autistic spectrum often are disinterested or ignore social interaction, and they make rare to no eye contact. However, in the case of Asperger's or high-functioning autistic spectrum, such individuals are often highly interested in social interaction. However, their inability to read facial expressions and difficulty understanding social interaction leads them to act inappropriately, which makes successful social interactions difficult to have despite the interest. One example of this is excessive eye contact, where such individuals, until they've been trained socially, will actually stare down people when they're interested instead of being able to have a normal amount of eye contact. Another difference is with speech. So in low-functioning autistic spectrum, speech is delayed and people may even be nonverbal. However, in the case of high-functioning autistic spectrum, speech is normal, though grammar and word choice can be a bit odd. Also in low-functioning autistic spectrum, visual spatial skills are preserved. However, there are strong visual spatial skill deficits in the case of high-functioning autistic spectrum. This can often be seen if one attempts to play ball with someone with high-functioning autistic spectrum, where if you're 20 feet apart, the person will throw the ball 5 feet. However, if you're 5 feet apart, they'll actually throw it way too hard and actually risk hurting you. So that inability to modulate how hard they throw the ball based on the distance is a very common visual spatial skill deficit you see in high-functioning autistic spectrum. Finally, in low-functioning autistic spectrum, the obsessive interests tend to be with objects and often things that spin. So there can be profound interest in things that spin. And so you'll often see young children will literally take a toy truck or car, turn it over, and just spin the wheel and be more interested in that and not play with it as a toy. In the case of Asperger's or high-functioning autistic spectrum, the obsession is with certain topics or activities. I've seen a wide variety of obsessive interests, from golf, where children will literally watch the golf channel 24/7 while they're awake, and only engage in other activities when there is a commercial on that's not about golf. These obsessive interests can take a wide variety of forms, from other sports to things like trains, frogs, dinosaurs, geology, and even in a few cases, medicine. So how common is autistic spectrum disorder? Recent studies suggest that up to 2% of males may have autistic spectrum disorder, though other studies put the number lower at approximately just under 1%, with about 0.5% of females in developed countries. Of course, in third world countries, these rates are much lower for reasons which we'll get into in a minute. This amount of autistic spectrum is a 10 times increase over the last 40 years. Now, interestingly, almost all of the increases at the high functioning end of the spectrum, where at the low functioning end of the spectrum, there's been a very minimal increase in diagnosis. In fact, there was a study done in published in October of 2018 out of Finland, that definitively linked pesticide levels in mothers prior to birth with the formation of autistic spectrum disorder by 8 years of age. And what was so striking was the ratio between the rate of autistic spectrum disorder and pesticide level were perfectly linear. So it's very important to note that this increase is not just due to improved diagnosis and screening, even though this has clearly contributed to at least to some degree. However, interesting, the rate of autistic spectrum is likely actually to grow more due to the improved diagnosis and screening of females, where the disorder is more subtle and harder to pick up. So what causes autistic spectrum disorder? Obviously, genetics plays a large role in addition to the previously mentioned pesticide exposure. And of course, maleness is a major risk factor as well. We also know that in utero, brain damage in utero or abnormal brain development also can increase the risk of autistic spectrum disorder. This includes things like viral infections during pregnancy, inadequate folate or other vitamin deficiencies. Also being deprived of oxygen at birth or during the pregnancy are also significant risk factors. We also know there is immune dysfunction, particularly in the immune system of the central nervous system or the immune system of the brain, which appears to play a role, but this is a very complex process and we're just beginning to understand it. As we stated in the last slide, prenatal exposure to pollution and pesticide are also significant risk factors. It's important to note that vaccines have absolutely been disproven as a cause of autistic spectrum disorder. And in fact, the scientist out of England who originally proposed this theory was later discovered to have falsified all the data used to make that assertion, make his claim, and that he was found to have engaged in other fraudulent activity and is currently in prison due to engaging in fraudulent activity. One thing to note is that you tend to see heritability through the female side, because when males are affected by autistic spectrum disorder, they tend not to reproduce or reproduce at a much lower rate, whereas females with autistic spectrum disorder often are able to get along with males fairly well and are able to reproduce, thus passing on their autistic spectrum genes to their sons. So, how do we diagnose autistic spectrum disorder? First, you have to have a formal neuropsychological evaluation by a certified agency or tester, which is different from screening test. And in fact, this formal neuropsychological evaluation, which is distinct from a typical neuropsychological evaluation, is required for most of the additional services offered in the United States to autistic spectrum disorder. Now, screening is typically done with the MCHAT-R currently, and it's typically done between 18 and 24 months. If you want to learn more about the MCHAT, you can look it up through the autismspeaks.org, which is the main advocacy organization for autism in the United States. In the case of Asperger's or high-functioning autistic spectrum, it is usually diagnosed later. It can be reliably diagnosed as young as about 4 years of age, but more typically, it's diagnosed during elementary school as the child begins to have increasing problems socially and difficulty getting along with teachers and peers. Just remember that applied behavioral analysis and school services through an individual educational plan or an IEP often require formal ASD testing prior to receiving those services. If you're looking for an agency for testing and or ABA therapy, it's a good idea to check with your local or state autism society, since they often have the most up-to-date list of local resources for your area. Let's take a moment to look at disorders that mimic autistic spectrum disorder, because oftentimes the question is not if there's a problem in the child, it's merely what is the problem in the child. So the difficulty is not distinguishing between a child with autistic spectrum disorder and no condition, but rather between autistic spectrum disorder and another condition. So some of the examples are things like severe shyness and selective mutism, where the child will not speak to strangers, can often be mistaken for autistic spectrum due to the avoidance and tendency toward being nonverbal. Also, early deprivation, such as being raised in an orphanage with limited human contact, can induces a type of reactive attachment disorder known as inhibited reactive attachment disorder. This, due to their avoidance and tactile defensiveness, that can often be mistaken for autistic spectrum disorder. Similarly, individuals with low IQ can often be mistaken for autistic spectrum disorder, particularly if they engage in a lot of rocking or headbanging, which are more common to low IQ than they are to autistic spectrum disorder. Of course, ADHD and oppositional defiant disorder, ODD, and conduct disorder, or CD, can be mistaken due to poor social skills and, of course, aggressive and prolonged outbursts. Bipolar disorder and PTSD both produce explosive tantrums, which can be mistaken. A more rare condition that you may not have heard of is known as PANDAS or PANS, which is an autoimmune disorder consisting of severe tics and sudden onset OCD, can sometimes be mistaken for autistic spectrum disorder, mostly due to the OCD symptoms. Finally, there's another condition known as autoimmune encephalitis. These conditions are typically autoantibody conditions, and the best known of which is the anti-NMDA receptor autoimmune encephalitis, which is particularly known for its sudden loss of language with the onset of the disorder. I've personally seen advanced cases of anti-NMDA receptor autoimmune encephalitis that actually resulted in the patient having severe autistic symptoms, even though they clearly had the autoimmune disorder that triggered it. So how do you treat autistic spectrum disorder? So early diagnosis is critical, since early behavioral therapy has been shown to alter neurological development and clearly improves outcome. The two most common types of behavioral therapy are applied behavioral analysis, or ABA, and the Early Start Denver model. They're both well-validated behavioral treatments, though the ABA is probably the more commonly available of the two. It's also important to treat associated medical problems, since they can trigger a lot of the tantrums and explosiveness, especially if there's some type of GI issue, such as abdominal pain, nausea, diarrhea, and so forth. Of course, ear, nose, and throat disorders, since children with autistic spectrum disorder tend to have more allergies, which can then exacerbate their behavior. And of course, epilepsy, which can significantly complicate the child's recovery and treatment from autism if the epilepsy is not identified and treated. Of course, social skills training is critical and should be ongoing, as it can take quite a long time to develop. Perhaps the best way to think about it is that in the case of social skills, people with autistic spectrum disorder can learn them, but it's like an adult learning a new language, where it takes lots of repetition and practice, and mere exposure to the new language is insufficient to develop significant skills. Finally, it's important to remember that medication has a limited role, and it's mostly due for either associated conditions or for limited things such as the aggression, anxiety, depression, and of course ADHD symptoms that are often highly comorbid with autistic spectrum disorder. Now let's take a moment to get into the medications used in autistic spectrum disorder. Two of the most commonly used medications are risperidone and aripiprazole. Since they both have FDA approval in the United States for irritability and aggression in autistic spectrum disorder down to 5-year-olds in the case of risperidone and 6 years of age for aripiprazole. These are both atypical antipsychotics and, of course, unfortunately have very significant side effects. Now, it's interestingly to note, risperidone does seem to be the more effective of the two when it comes to the severe aggression and outbursts, but it also has more significant side effects in terms of more significant weight gain, and also has the unfortunate side effect of causing males to begin to develop breasts, which are known as gynecomastia. Another type of medication that is used for the outbursts and aggression include alpha 2 agonists and beta blockers. These are particularly good for the impulsivity associated with the explosiveness. They're both types of blood pressure medications, and so they don't tend to have the issues with weight gain, though they can have some sedation and, of course, dizziness. SSRIs and SNRIs, these are antidepressants that are particularly effective for anxiety, are often used, and especially in high-functioning autism when it comes to depression, because that often is a significant problem during adolescence and young adulthood due to the significant social struggles. ADHD is also quite comorbid with autistic spectrum disorder, and so both stimulants and non-stimulants are frequently used. However, of the stimulants, amphetamines such as Adderall are often better tolerated than methylphenidate-based products such as Ritalin, Concerta, or Metadate. Finally, sleep medication is often necessary due to both the hyperactivity as well as the high anxiety often present, which can impair sleep. Agents such as melatonin, antihistamines such as Benadryl or hydroxyzine, as well as alpha 2 agonists such as clonidine are often used with good benefit. Risperidone is typically dosed from 1/4 milligram to about 1 milligram twice a day to get your best dose response ratio. Higher doses are sometimes used, but oftentimes they're less helpful due to the dramatically worsened side effects with only mildly improved benefits. Aripiprazole is often used in the range of 2 milligrams to 15 milligrams in adolescents at bedtime. This is a wider dose response ratio, but aripiprazole is often better tolerated in terms of weight gain, sedation, and due to a lack of gynecomastia. Guanfacine, which is one of the alpha 2 agonists, is often one of the best to use during the daytime because it's not as sedating as clonidine, and it's used in the range of 1 to 4 milligrams per day, either divided or in a single dose of a long-acting form. The main thing to note is that in younger children, guanfacine is prone to causing a drunk-like reaction where the child is confused and flails, known as disinhibition. While it's particularly common under 7 years of age, on rare occasions you can actually see it even in adolescents. When SSRIs are used, the most common two agents used are fluoxetine or Prozac, typically in the higher dosages, as much as 60 to 80 milligrams a day. Similarly, sertraline, also known as Zoloft, is used in high dose, about 150 to 200 milligrams a day. Lower dosages, while they may help the depressive symptoms if present, they often are not strong enough to address the severe OCD and anxiety symptoms associated with autistic spectrum disorder. In the case of Adderall, dose range is typically 10 to 30 milligrams a day, but due to negative effects on heart rhythms and rare cases of sudden cardiac death, it's very important to get an EKG first and to not use Adderall in individuals who have any type of cardiac abnormality, particularly those with endocardial cushion defects. Concerta, which is a methylphenidate product, is the most commonly used methylphenidate product, and it's dosed 18 to 54 milligrams typically, though 72 milligrams a day is the upper limit. The most common problems with Concerta that relative to Adderall is that you see higher rates of irritability, dysphoria, and even suicidal thoughts on Concerta relative to Adderall. Finally, for residual OCD and residual anxiety, buspirone, also known as Buspar, is sometimes helpful in certain individuals, even if they've already failed fluoxetine or sertraline, or if they're currently on maximal dosages of fluoxetine or sertraline. Now always remember, medication doesn't help much. It helps 20 to 30% at best. And always remember that ABA therapy and other behavioral therapies are the primary treatment for autistic spectrum disorder. Most outbursts are due to changes in routines and environment. It's very important to wait at least 4 weeks between major environmental changes such as shifting from summer to school in the fall before considering medication adjustments. It's also helpful to identify triggers. That way they can be avoided or you can work around them, which relieves the need of using high-dose medication to address those issues. It's important to always ask yourself if the benefit of the medication is actually worth the adverse effects. And it's not unusual to find that the benefits of medication are so limited that they are not worth the adverse effects. When using medication, it's important to monitor for seizures, anorexia, mania, and psychosis, since all 4 conditions are somewhat more likely in autistic spectrum disorder than the general public, and the nature of autistic spectrum disorder can increase the risk of some of these. Always remember that kids with autistic spectrum disorder do much better as adults than they do as children. So you really can't predict how well they'll do until they become adults. Also, when using medication, always remember to start with low dosages and go up slowly. And remember that unusual reactions are more common in autistic spectrum disorder. So what are some of the comorbidities of autistic spectrum disorder? ADHD is highly comorbid with high-functioning autistic spectrum disorder, but it's more moderately correlated with low-functioning or classic autism. Of course, anxiety is very common in autistic spectrum disorder, and OCD-type symptoms are also highly comorbid, as well as anorexia nervosa. In fact, more accurately, you might think of autistic spectrum disorder as being a significant risk factor for anorexia nervosa in both males and females. Also, high-functioning autistic spectrum individuals tend to have higher rates of depression as teens and young adults, often related to the difficulties interacting with their environments and with difficulties in social interaction. Bipolar disorder is mildly comorbid with autistic spectrum disorder, especially if there is comorbid epilepsy with the autistic spectrum disorder, but still it's not guaranteed, and so you have to monitor carefully for that emergence. There is a slight comorbidity associated with schizophrenia and autism, though it's relatively insignificant, as most individuals with autistic spectrum disorder do not go on to develop schizophrenia as adults. Interestingly, individuals with autistic spectrum disorder have higher rates of bisexuality and pansexuality, as well as homosexuality and transsexuality. So it's very important to monitor for issues related to this in children with autistic spectrum disorder as they move into puberty. Finally, it's important to remember that genetic syndromes do not preclude a diagnosis of autistic spectrum disorder. It's well known that individuals with Down syndrome are capable of developing autistic spectrum disorder. Similarly, individuals with fetal alcohol syndrome and Fragile X can also develop autistic spectrum disorder. So genetic conditions do not preclude such a diagnosis. Thank you for listening to this lecture. If you like it, please hit the subscribe button and, of course, the like button. I will have more lectures coming out on a variety of mental health topics, so if you're interested in this sort of thing, stay tuned and be sure to hit the subscribe button so you'll know when they come out. If you have a question for me about any of this, please leave a comment. Please leave your question in the comments below, and I will do my best to get back to you with an answer. Thank you again for watching, and until next time. Now, the one exception to this, of course, is when males have high-tech jobs or skills and command significant resources, they are able to marry and reproduce. Bill Gates is the ultimate example of this, being the founder of Microsoft and being married to Melinda with, and I believe, 2 children.